In this week's module, we'll be covering chapters 19 through 22. Welcome again to another week. So we'll be focusing on GI and GU systems. And I hope by the end of this presentation, you'll be able to understand the underlying anatomy and physiology, perform comprehensive exams, and then identify key concerning symptoms in your patients. Let's get started. So when assessing the abdomen, let's start with abdomen, it's very important to recognize the key anatomical landmarks, like the xiphoid process and costal margins from the upper borders, while the iliac crest and anterior superior iliac spine, inguinal ligament, and then symphysis pubis define the lower borders. The rectus abdominis muscle and linea alba are also central reference points. So it's very important to get familiar with these borders or these landmarks, which helps to come up with the accurate documentation. So beneath the abdominal wall lie the vital organs of the digestive and urinary systems. For example, the right upper quadrant houses the liver and the gallbladder, and while the left upper quadrant contains the spleen and then the stomach. So the descending aorta runs centrally, and the intestines occupy much of the lower quadrants, as you can see on that image. So knowing the three-dimensional layout of these structures is very essential when performing palpation and then percussion, allowing you to interpret the clinical significance of any tenderness or masses that you may notice. So the abdomen is clinically divided into 4 quadrants. We categorize them as right upper, left upper, right upper, right lower, right left upper, and then left lower. And so the right upper quadrant contains the liver and then the gallbladder mainly. The left upper quadrant includes the stomach and the spleen, and then the left lower, which is descending, it houses the descending and the sigmoid colon. And then the right lower quadrant is notable for the appendix. Most of the times is most common. So memorizing these quadrants is very fundamental for generating an accurate differential diagnosis based on the location, for example, the patient's pain. And remember, abdominal pain, well, so as the back pain, which sometimes go hand in hand, are some of the most common presenting symptoms in the primary care. So the pelvic cavity acts as a protective basin of the urinary bladder, the genital organs, and intestinal loops. So when assessing this location, this area, pay close attention to concerning GI symptoms. Like indications include, like I mentioned, abdominal pain, nausea, vomiting, loss of appetite, and those are also most common. Ask about any pain with swallowing, any dysphagia that the patients might have been experiencing, any jaundice that you might have noticed on the lips or anywhere on the skin. That's very important too, or on the abdomen. Jaundice may appear elsewhere, but look at the abdomen especially. So moving to the GU system, inquire about suprapubic pain or any dysuria, any urgency, any nocturia, any frequency. Those are symptoms of like UTI in older adults. Hematuria also, it's a red flag requiring immediate investigation. Assess for in flank pain or pointing to the kidney stones. So when documenting abdominal or urinary pain, utilize or use your old cards mnemonic, which is very important to provide necessary context for differentiation. But you can also gather like past medical, surgical, or social history to help you come up with an accurate diagnosis. So for the liver disease, which can stem from, for example, infectious hepatitis or due to like also alcohol use, especially if it has been for a long time, or even non-alcoholic fatty disease is becoming also common, again, because by metabolic syndrome. So other genetic conditions like Wilson disease may also be risk factors. And so your abdominal physical assessment should follow a strict sequence which you are already aware of. It's quite different from other assessments. Start with inspection, percussion. Inspection, auscultation, then percussion, and then palpation. All right, so this will help you, for example, palpate the liver and then spleen to estimate their size. Percussion, for example, over the costivertebral angle helps assess for any kidney tenderness, and then percussing this pubic area will help evaluate any bladder related uh, conditions. So recognizing the signs of, for example, peritonitis is very critical clinical skill. For example, when you are assessing voluntary guarding, voluntary rigidity, and then any rebound tenderness, which may signal severe abdominal inflammation. So, in addition, you should also be more familiar with some special techniques to assess specific conditions like the shifting dullness for ascites, and always you can also always conclude your abdominal assessment with health promotion, discussing preventative measures like for viral hepatitis and the screening guidelines for any colon cancer, but especially depending on your patient's age. For example, 45 for those with the high risk factors. Actually, it's now 45, depending on the newer guidelines. Used to be like 50, and I believe most recently it was changed to 45. So for male genitalia anatomy, which is part of chapter 20, so just this is a quick review of the anatomy and physiology that we should be familiar with. This is very important also to understand the male reproductive system. If there are any changes, any abnormalities that you may observe here, this is very important to report it, but we'll give you an opportunity during the second residency to do a very comprehensive or a focused assessment of the male genitalia. There's some of the landmarks like the groin, which is a complex anatomical region, may be prone to hernias. For example, the anterior superior iliac spine, the pubic tubercle, and then the inguinal ligament. So understanding the path of the inguinal canal from the internal to the external ring is very crucial when you're assessing for any inguinal hernias. So, for example, a male sexual development is driven by some of the complex endocrine cascade involving some of the hormones like LH or FSH, which help regulate testosterone production and then sperm production, and also secondary sexual characteristics as male are growing up. So some of the symptoms and infections that you might notice, which are concerning, it's any penile lesions, any discharge, or skeletal swelling and then pain. Always conduct your comprehensive, it's a focused assessment, and ask about also sexual history if, for assessing like STDs risk. Symptoms like fever, dysuria can also point to uh, prostatitis, inflammation of the prostate. So systemic signs such as a rash or joint pain also may indicate gonococcal infection or secondary syphilis. Also, let's talk about how you, so you have to inspect the penile skin and glands or regions. If you want to check for urethrum, check for urethrometers for also discharge. This is another uh, way of making comprehensive assessment of the male genitalia. So palpate the skeletal contents and identify the testes and epididymis, noting any masses or tenderness, evaluate for any hernias. Yeah, that's what I'm always talking about. Let's talk about again. Let's talk about hernias again, and examining the inguinal canal while the patient coughs, for example, or bears down. This is very helpful when we are assessing for those hernias, which help us differentiate between types of hernias based on their presentation. So this is a very key skill which comes with time. For example, indirect hernias are the most common, which originate from the internal inguinal ring, and then often descend into the scrotum, touching, for example, the fingertip of the examiner. How are they different from direct hernias? Those originate closer to the pubic uh, tubercle and then bulge anteriorly. Femoral hernias are another type of hernias which occur below the inguinal ligament and then are also more common usually in women. Always conclude your assessment by providing counseling on testicular self-examination and of course the prevention of STDs or HPV or HIV. So this is anatomy and physiology again of the female genitalia. We'll give you an opportunity in the second residency to conduct or to perform an assessment. And so understanding, for example, the spatial relationships between the bladder, uterus, and the rectum, as well as the anterior and posterior of fornices is very essential when you are conducting a comfortable and diagnostically accurate bimanual pelvic examination. So, deepening our anatomical review, the female pelvic cavity houses the productive organs. This is more about also anatomy and physiology, which we'll not delve into right now, but this is just a quick reminder of the anatomy and physiology of the female pelvis. And it's vital also for diagnosing common conditions like fibroids or endometriosis. So, like I mentioned, for male assessment, it's very important to collect health history spanning their reproductive life cycle and from when they were preteens up to the menopause. Ask detailed questions about menstrual cycle, any abnormal bleeding that they might have experienced, which may indicate polyps or fibroids. Any pelvic pain that they might have had, sexual health, any risk of STIs. And so as you prepare for physical exam, so ensure you have all the equipment. This is something we'll do in the second residency as you do the pelvic examination. And you will have an opportunity to perform this. But every single assessment should also conclude with counseling on health promotion. For example, women will be focusing, you have to focus on cervical and ovarian cancer screening, managing menopausal symptoms. So when we look at chapter 22, it covers the rectum, prostate, and anus. These are key anatomical structures here, which you can review to better understand their role in your assessment. So, for example, collecting history about rectal and prostate systems helps evaluate any changes, for example, in bowel habits, presence of any bloody stool, and this helps to differentiate between different conditions. For example, we have IBS and Crohn's disease, which may be differentiated by whether they have bloody diarrhea or is it constipation or do they also have the bloody diarrhea. Also, BPH is very common in the clinical setting, in the primary settings, and sometimes it may be confused with UTIs. And so when patients present to the clinic, whether they have BPH or not, even before ordering PSA, it's very important to order AUA. Prostate cancer screening is recommended beginning at age 50, and then for average risk men, 40 for high risk individuals. We use PSA, that's what I mentioned, and then also DRE, which is not very common nowadays. So for physical exam, it's very important to ensure lateral decubitus positioning so that DRE may be done, but you also get an opportunity to perform these tests during the second residency. This is the end of our presentation today. Let me know if you have any questions or concerns. But this is just a quick overview about what we'll be talking about this week. And it's not a comprehensive review, but just to give you, highlights about what we are discussing this week. Thank you.